Principles of neoplasia. Cancer is the second leading cause of death in the United States. It is something that, more than cardiovascular disease, exacts a higher toll on patients. The associated mortality and emotional and physical suffering that comes with it. Patients in the public ask, when will there be a cure for cancer? The answer is that it's difficult because cancer is not one disease, but rather a disorder of multiple profound growth dysregulation. So it's really hard to pinpoint exactly what causes it. And often, many cases, there is no known cause as to why the patient starts with this neoplastic growth. Neoplasia and cancer come from a Greek word for crab, carcinoma. So this is where we get carcinoma. And tumor means swelling. Neoplastic cells are either benign or malignant. You can still have neoplastic growth, but it's more of a stable situation if it's benign, and then obviously we have concerns if it's malignant. We are going to discuss tumor nomenclature, and that is how we determine exactly where the growth has originated. And if it's benign versus malignant, you're going to see features of the nomenclature that allow you to identify exactly what's going on by the name of the cancer. There are so many different types of cancer. What we just want you to be aware of is kind of how you are going to identify and potentially diagnose somebody with cancer. Basically, cancer is by DNA mutations. Pathogenic mutations are either induced by exposure to mutagens or they occur spontaneously as a part of aging. But we have the influence of that on the DNA. Genetic alterations are inheritable. They can be passed from daughter cells upon cell division. Then we also have the epigenetic component. So research is looking at the cellular molecular abnormalities that give rise to cancer and govern its pernicious behavior. These insights in turn lead to a revolution in the diagnosis and treatment of cancer. We are getting a lot better as we are getting personalized medicine, which we talked about a little bit in the genetics lecture, because we are looking for exactly where those DNA mutations are, and then the treatment comes in and targets that. Hallmarks of neoplasia is that it is unregulated growth, meaning that there is no turn off. So remember how we said in cellular biology, pretty much everything that can be turned on needs to be able to be turned off. Hallmark of neoplasia is that it's unregulated cell growth. It is irreversible. Once we progress into a cancerous process, it is irreversible. And we talked a little bit about cellular injury with metaplasia and dysplasia. Remember how we said that it is reversible if we catch it in those early stages, but once we get into carcinogenesis, it is irreversible. It is monoclonal, and that basically means that it's from one single mother cell, and I have an example of that. So this is called clonal proliferation. So that first mutation is inactivation of the APC. What that means is the cell seems normal, but is predisposed to proliferate excessively. At the mutation of the second, it is an activation of the KRAS, and we're going to talk about some of these events a little bit later. Cells begin to proliferate, but it's otherwise still normal. Then we get into the third mutation, loss of DCC, overexpression of COX-2. These are just mechanisms by which these cells are going to have that mutation. So now they begin rapidly multiplying. And then we're going to see structural changes within the cell. Fourth or later mutations, we have loss of TP53. We're going to talk about that a little bit later. That is a regulation process when cells begin to become unregulated. So now we have cells uncontrollably growing, and they look obvious abnormal. But this is what the cascade looks like, but it is from one mother cell. So one single mother cell, and that allows it. And this is actually how we detect hyperplasia versus neoplasia. If it's from multiple cells, then it is not considered monoclonal. And then that is high yield, meaning that we can say, all right, if we see monoclonal features, we know that it's a neoplastic process. So this is just a synopsis of kind of that process. This is why we do cancer screening. So it begins as one mutated cell, takes approximately 30 cell divisions before earliest clinical symptoms are detectable. This is where screening comes in. If we can't screen for something, then by the time that is detectable, it is usually pretty advanced, and there's a risk of metastasis at that time. So every cell then thereafter has increased mutations even from the first mutation. So it just keeps growing and growing. And that can lead to problems with treatment because there's so many mutations, it's really hard to pinpoint. Screening is to catch that dysplasia, which we talked about, which is precancerous before carcinoma, and then carcinoma before symptom. Do we catch it when it's already advanced? Usually, if it's detected late, it's poorer prognosis. There are problems with low symptom producing cancers. And what we mean by that is, with, let's say, lung cancer, because it's such a big area, a lot of times there are minimal symptoms before the cancer has grown. So here's an example of the cancer screening. So when we're doing a pap smear, we're looking at cervical intraepithelial neoplasia. And that is basically cervical dysplasia before carcinoma, and that's what your pap smear is for. Mammography, we're looking for in situ breast cancer before invasive or clinically palpable. PSA, and this is a digital rectal exam, is to detect prostate cancer before it spreads. When we're looking at colon cancer, we're looking at occult testing, which is your send home kits for FIT testing or your fecal occult blood testing, and then colonoscopy, and that is to identify an adenoma before it progresses into carcinoma. All right, there are fundamental features that are consistent with both benign and malignant growth. So we're going to take a look at a few of these. Most cancers, most benign findings fall in these classifications. However, there are some tumors, some cancers that are not defined necessarily by all of these features, and they defy that easy characterization. But in most cases, they will fall into these categories. It has a well-defined capsule, so that means that it is looked at definitely different from the surrounding tissue. So it has a capsule around it. So features of benign include growing slowly, not invasive. That means that it has not gone through that basement membrane. Well differentiated. So differentiation is to the extent which the neoplasm resembles the parenchymal cells of origin. We look at functionality, also morphology of it. So it looks the same. It resembles the parenchyma. So if it's well differentiated, it means that the cells closely resemble their normal counterparts. By contrast, if it's poorly differentiated, it means that the malignant neoplasm exhibits a wide range of parenchymal cell differentiation. There is high potential that it has invasion into adjacent tissues, metastasis. Well differentiated, it maintains functional capability. The other thing that we look at is the mitotic index. So when we're talking about mitotic action, this is basically cell growth. So what is that cell growth index? So when we do grow slowly, we have a low mitotic index on the lower side. It's not a fast, aggressive cell growth. Less cells are dividing. That's good when we're talking about cancer. If we have a high mitotic index, that means we're getting more proliferation, more cells dividing, and then that increases the risk of more mutations. And then high yield is that it does not metastasize. That is a hallmark feature of a benign finding. So on the opposite, for malignancy, grows rapidly, aggressive. It is not encapsulated, meaning it is poorly kind of defined. It does invade those local structures, and that again leads to that poorly differentiated status, meaning it does not look like the parent tissue. It has that high mitotic index, meaning we're getting a lot of cell growth, and it metastasizes, able to spread. Another important distinction is called carcinoma in situ. This is where we want to kind of catch cancer. So if we couldn't catch it in screening, we really want to catch it in this situation because it has not spread into the basement membrane and it doesn't metastasize. If we can't detect it by screening, then we want to get it in this in situ situation. So it's still a group of abnormal cells that remain in place when they're first formed. High yield, not penetrate basement membrane. They have not spread, potentially become cancer and spread into the nearby tissue. This is called stage 0 disease. It is usually in the breast, cervix, skin, oral cavity, esophagus, and bronchus. So we hope to find it in these locations. Carcinoma in situ can have three fates. It can remain stable for a long time, meaning that it does not spread. It can progress to metastatic disease, or it can regress and disappear. So now let's take a look at how do we do the nomenclature. So we have the lineage, so we have benign neoplasias, and then we have the malignant plasias. The parenchymal tissues, which is the epithelia, the skin, the glands. If it is a benign, we call them papillomas or adenomas, depending on the location. And if it's just oma, usually means that it's a benign finding. If we look at the malignant nomenclature, carcinoma, adenocarcinoma. So then we bring in carcinoma. Moving on to mesenchymal, which is your connective tissues, blood vessels, lymphatic systems. So if it's benign, lipoma, fibroma, chondroma, lymphangioma. Again, you see the endings here. Then if we get into this malignancy, it is a sarcoma, and there's examples of that. So a fibrosarcoma or a liposarcoma. Lymphocytes, so this would be our lymphomas or leukemias. There is no benign finding. If there are abnormalities within that system, it is a malignant finding. Melanocyte, if it's benign, it's called a nevus or a nevus. And if it's malignant, we get melanoma. And this is kind of a misnomer because, yeah, we have that oma, but it's just understood that melanoma is malignant. Neuronal tissue, gliomas and meningiomas. Again, you will see some features that think it's benign just because of the nomenclature of this. So meningeal sarcoma, glioblastoma, things like that add to the malignancy of it. So these classifications of these tumors, the other thing that we're looking at now is this genetic testing, and that is what's termed personalized medicine. An example would be breast cancer, and the tumor is expressing genes such as BRCA1 or 2, epithelial growth factor, HER2 receptors, there's progesterone receptors, estrogen receptors, and then there is something called triple negative, which means that it has none of those features. This is where genetic testing comes in and receptor analysis. And this is all done after biopsy. So this further subdivides the cancer, therapeutic prognostic treatment, so we can get a lot more personalized with how we're going to treat the cancer. And that's where genetics is high yield. When we look at cancer epidemiology, it is the second leading cause of death in both adults and children. What I want you to understand is skin cancer is the top of adults for female and male, but it is non-fatal most of the time. The only skin cancer that really gets fatal is the malignant melanoma. Skin cancer does sit atop of here for adult, most common, but it is not mortality rates. Here again is taking a look at what is the most common, but then what does cause the most death. So you see for men, male, female, breast and prostate is the most common, followed by lung, followed by colorectal. So then when we look at mortality rates, lung moves up to number 1. And why is that? Because we have poor screening processes. And usually by the time that we find it, it's too late and it's metastasized. Breast and prostate move down a little bit, depending on when and how aggressive the type of cancer it is, that increases the mortality rate. Colorectal, we have good screening for this, right? As well as breast and prostate. We have good screening for both of these, and that's why they move down. As you can see with children, accidents are still the number 1 cause of death. But then cancer is right there at number 2. You can see the estimated cancer deaths by site and sex. Here's lung and bronchus. By far, estimated death, it increases. Breast 14, and then you go prostate 8 for the men. When it goes over to the incidence, so what do we see? Breast moves up, lung moves down, and over here, prostate moves up, lung moves down, and that basically comes back, and see what we see here. All right, so what is the basis of the epidemiological studies? What it looks like are lifestyle and environmental risks that they have found. Nutritional intake, alcohol, smoking are high yield. Environmental would be your skin exposure to UVB and UVA, natural medical radiation, workplace exposures, and involuntary and unknown exposures. There are a lot of environmental disruptors and mutations. Sexual practices, lack of exercise, obesity, and overweight does predispose you to some cancers, and we'll take a look at that a little bit later. Socioeconomic factors, getting access to medicine, getting detection, and then obviously cancer treatments. And then the exposures, water, air, soil does matter. You get exposed to it all the time. The other thing that they look at is chronic inflammatory states. So what is the environment? If you have chronic inflammation, there is that environment that facilitates tumor proliferation and metastasis. There's also the immune complexes. It just basically sets the stage for cancer neoplasia. Number one carcinogenic and most important cause of cancer is tobacco. So you can see there 1 out of 5 deaths, and yet is the single most preventable. They just have to quit smoking. And you can see here 80% male, 50% lung cancer death burden. I just included this. This is just to kind of see, 4,000 chemical agents, over known 60 carcinogens, and there is the big high yield ones that we know cause cancer. In addition to the lung cancer, it puts you at risk for anything where the smoke comes in contact. You're taking it in through the mouth. We have lip, throat, nasal cavity, sinus, esophagus. So let's take a look at diet. If we could summarize the bad things that you potentially could ingest, putting you at risk for developing cancer, there it is. I just love this. Absolutely love it. So here you can see may decrease the risk of some cancers, and that's that tea, breastfeeding, dietary fiber, spices and herbs, whole grains, fish with omega-3 fatty acids, beans, fruits, vegetables. So what is that really getting at? Whole foods, plant-based diet with some fish, okay? Also physical activity, healthy weight, caloric restriction, and that you have been breastfed decreases your risk. So then we have these controversial, so dairy, lean, unprocessed meat, total fat. Then we move up, may increase risk for some cancers, and you can see that Western diet. Also, obesity aids in the development of some cancers. Here are the cancers that are increased by having obesity. And remember, obesity is a BMI equal to or greater than 30. We consider overweight 25 to 30 BMI, and then ideal is 18 to 25. Endometrial, colorectal, kidney, esophagus, breast, and pancreas. Interesting enough, breast cancer postmenopausal presentation has a lot to do with obesity, and that's related to estrogen. They're looking at thyroid, gallbladder, liver, ovary, prostate, and non-Hodgkin's lymphoma as potentially being related to obesity. It is also a poor prognostic factor for several cancers, and then it's related to hyperinsulinemia. Sex steroids also have stimulatory effects. There's a lot of these receptors as we get into the microenvironment of the tumors. They love sugar, so if there is more sugar, there's going to be hyperinsulinemia, and that impacts the presentation as well as the prognosis. Other things that they're looking at are energy balance. So what is the energy expenditure and balance? And this gets into what is the lifestyle. We know if there's a sedentary lifestyle, it increases the risk. Physical activity is very important. There are further studies that need to be evaluated, whether the obesity drives the cancer or whether the energy balance has the greater effect on the cancer. We're going to look at the etiology of cancer now. So we have 3 classes of carcinogenic agents: chemical, radiant, and microbial products. We have 2 different types. We can have direct or indirect agents causing the issue. So if it's a direct agent, it does not require any metabolic conversion to become carcinogenic. So these would be alkylating agents, anti-cancer drugs. So the problem with treating cancer is sometimes you are treated with an alkylating agent. Well, then that alkylating agent can cause direct damage and further puts you at risk for more cancer later on. A lot of the anti-cancer drugs can cause this situation. If it's indirect, it requires metabolic conversion to a carcinogenic. These would be an example of hydrocarbons. Here is that process. So whether it's inhaled, ingested, synthesized by the skin, such as radiant energy, microbial products, whatever it is, the carcinogen gets in. It is then metabolically activated, and we get electrophilic intermediates. Usually we get detoxification, excretion, and the body takes care of it, whether the liver or the kidneys are trying to get rid of the toxic agent. If not, then we get binding in DNA and we start getting issues. A lot of times we will get DNA repair, or we end up getting apoptosis and cell death. If the cells are unable to do that, then we get permanent DNA lesion, cell proliferation, pre-neoplastic clone, and then we get neoplasia. So let's take a look at some common carcinogens. There are many more. I just put the high yield ones and taking a look at what they cause. Arsenic and arsenic compounds. This is going to be lung cancer, skin cancer if you get exposed topically. Asbestos, which we all know there's a special type of cancer called mesothelioma, and asbestos was formerly used in many applications before they realized that it was a carcinogenic. It's still found in old building tiles, placed in schools, in old homes. There's still a lot of it around. Then we have aflatoxins. So these are the things that are made when wheat grains are stored. It's a mold, and that mold puts off these things called aflatoxins, and then when the foods are ingested, it creates this liver cancer. Benzene, so this is high yield. These are patients who are painters. Other things, oil component, rubber, dry cleaning, adhesives, coatings, detergents. So then we have some heavy metals such as nickel or cadmium, and nickel, such as nickel plating, ceramics, batteries, byproduct of stainless steel arc welding. Cadmium, so this is in pigments found in solders, used in batteries, and as an alloy. Vinyl chloride, so this is a refrigerant monomer, adhesive for plastics, so this is big plastics, which are used all over the place. And this creates a specific liver cancer called hepatoangiosarcoma. Alcohol and smoking, many different types of cancers. Here are your oncogenic viruses: human papillomavirus virus, Epstein-Barr, hepatitis C, B, and then human herpes virus 8. They cause all types of cancers. Alkylating agents, so where would you get exposed to alkylating agents? So these are those, you have one type of cancer, you have to kill it related to an alkylating agent, and then it potentially gives a leukemia. This was pulled from the World Health Organization, and this just goes to show you, so in red are carcinogenic agents, in green are ways to off-put those carcinogenic agents. You can go to the website and take a look at it closer up. It is PDF format. Carcinogenesis. We're going to look at the basic pathway that most cancers start from. Have that initial damage to the stem cell DNA, whether it's a deletion, point mutation, whatever the cause of it is, we have this DNA damage. The fact that the initial damage is overcome, it does not kill that cell, so it is not lethal. And that's where we get this proliferation and unregulated cell growth. It is caused by carcinogens, certain inheritance patterns, those would be your genetic, and then it can be spontaneous and random, and this is what we say as bad luck. The carcinogens are chemicals, oncogenic viruses, radiation, and toxins. And we had already talked about those high-yield carcinogens. So those mutations will eventually disrupt 4 key regulatory systems, allowing for tumor promotion and progression. So basically, we're going to get growth and spread. They are proto-oncogenes, tumor suppression genes, the genes responsible for DNA repair, and then regulation of apoptosis. Accumulation of these mutations occurs in a stepwise fashion over time, and that's what creates cancer. The hallmark of this is uncontrolled cellular growth, and we're going to talk about it in a minute. But everything that we just talked about on that prior slide is here in a nice little schematic. So we have a normal cell, we have that induced mutation, we get initiated precursor stem cell-like properties. We're initiating mutation at this point. So then we have additional driver mutations. We have acquisition of cancer hallmarks, which we're going to go into momentarily. We have that mother cell, and then we have additional mutations. Every time it mutates, we get more mutations. We get those subclones, but it's all related to this mother cell. And then we get genetically heterogeneous cancer, and then ultimately you are diagnosed. And as you can see here, we have one mutation, but as we go, we get all those passenger mutations, driver mutations, they keep adding on. So let's take a look at the biology of the cancer cells. So what happened? It is a complex genetic disease. It has cumulative genetic changes during aging. So those are the patients that we see that got diagnosed. Age alone is a risk factor for developing cancer, because of all the times that our cells turn over and divide and make new cells. That is age related. Then we have all of these mutational or epigenetic situations which aid in these point mutations. We have chromosomal translocations, which we talked about in genetics, gene amplification, driver mutations, epigenetics, and then we have ultimately malignant transformation. So this is kind of just a little synopsis of, we are going to talk about proto-oncogenes, and then we have an activating mutation, whether it's a coding mutation, regulatory translocation, gene amplification. That is that activating mutation. So then we're going to get a functional product, which is maybe an abnormal protein, a new protein, a weird protein, excessive amounts of protein, and then that all leads to continued issues on the pathway. Another thing that happens with the cancer cells is they actually evolve genetically over time. So once established, the tumors evolve genetically during their outgrowth and progression under the pressure of the Darwinian survival of the fittest. After the cell has gone through about 30 cell doublings, and that's kind of an underestimation of the fraction of cells in all tumors, because there are parts of them that die by apoptosis. During that expansion process, individual tumors actually acquire those mutations at random, and then this drives more driver mutations, and then it basically creates this tumor microenvironment, and the cells that are the most fit will win, and that permeates this tendency of tumors to become more aggressive over time. And that is where we get tumor progression. This also explains some of the changes that happen after chemotherapy or tumor treatment. It is a resistance that is documented after a patient has undergone therapy already, while it would be resistant to the same therapy. So one of the first classes of genes that is affected by carcinogenesis are these proto-oncogenes. Proto-oncogenes are necessary for cell growth and differentiation. They are non-mutant. When they get mutated, they go to oncogenes. So proto-oncogenes, good, oncogenes, bad. So what happens if we get those mutations of the proto-oncogenes, leads to oncogenes and unregulated cellular growth. Proto-oncogenes are made for cell growth. That's their job. When they are mutated, then we get increased proliferation and unregulated cell growth. A couple of them include growth factor receptors, signal transducers, nuclear regulators, cell cycle regulators. Three main mechanisms by what we get that conversion from a proto-oncogene into an oncogene, and that is a deletion or a point mutation. And we either will have a hyperactive regulation of the gene or a loss of regulation, and the gene is overexpressed or underexpressed. Gene amplification is when the normal protein messenger RNA is overexpressed. We get gene amplification at that time. Chromosomal rearrangement, this can also be hyperactive or overexpressed depending what it is. Translocations, the Philadelphia chromosome, that is the ABL BCR, and that creates this hybrid gene, and that is related to a translocation of 9 and 22. That's high yield for chronic myelogenous leukemia. So when we talk about that unregulated cellular proliferation, basically normal cells only enter proliferation if growth factors are present, and one of these ways are the tyrosine kinase receptors. So here's an example of that. We have the RAS, there's the D-cyclins, which actually are in the cell regulatory cycles. Normally we have ways to stop RAS activation, such as GAPs. But what happens is the cancer is very shady, I guess is the best way to call it, because what they do, normally when you have your receptors, you will have a cell nearby that's actually putting out the ligand. You hardly ever have a cell that has the production of the ligand and the receptor on the same. Well, what happens when a cancer cell hijacks a cell, what it does is it actually creates this environment where it will make the transcription factor, growth factors, whatever, and it will secrete them, and it basically comes over and then binds to itself. So it's a self-sufficient cycle. That creates the self-sufficiency that we see in cancer and allows for unregulated cell growth because it basically just keeps doing it. When we're talking about TKR receptors, RAS decyclins, it's second messenger. So you're going to have ligand activation of the receptor comes in. You have a couple bridging proteins. You have an inactive RAS. We get activation. You have GDP, GTP. Here's GAP. So GAP usually applies the brakes. If we have activated RAS, then we are going to go into the nucleus and get activation of transcription, and then we're going to start getting cell growth. This would be unregulated if we have that activation of RAS and we don't have GAP to turn it off. That is one of the ways that we get this uncontrolled cellular proliferation. So then we have the oncogenes, and cancerous cells characteristically express mutated or overexpressed oncogenes, like I was saying earlier. And then we get these oncogenes. They are independent of normal regulatory mechanisms, meaning they cannot be turned off. And they can affect any portion of the growth factor pathways. There are many pathways. It's not only RAS. This is just an example I've provided here so you can kind of see that process. They also stimulate their own growth, and this is called autocrine stimulation. When this happens, that they basically make their own ligand, comes over and stimulates the growth factor receptor. Another way that they can do it is they can increase the number of the receptors. They can secrete their own growth factor, but then they can also upregulate and make more growth factor receptors, allowing for this to pump out more and go to all kinds of growth factor receptors. So that is autocrine stimulation. Another way that they can do this is they can actually mutate at the RAS level. And this results in unregulated cell growth just because this receptor does not turn off to GAP. So here are a couple selected oncogenes and targets. So if you look in your book, you'll see the overexpression or it's an amplification. So you can see the mode of activation of the tumor. Same here is what I have included so that you can see PGF3 has an amplification risk or an overexpression risk. And we'll see that in osteosarcoma, breast cancer, melanoma. KRAS, there'll be an issue with the GDP and phosphate. Again, that growth factor stimulation, the on and off switch, does not work correctly, and we'll get a couple cancers. Apparently I can't spell colon, so it's colon cancer, carcinoma. That's supposed to be colon. A transcription factor activator would be related to translocation, which I talked about. Burkitt's lymphoma is this one down here. This is the Philadelphia chromosome here for chronic myeloid leukemia. Down here is the Burkitt lymphoma, which is the MYC and Ig gene translocation. So that would be a T8 and 14 translocation there. When we're talking about CDK4, that is actually a cyclin-dependent kinase. And we could get an amplification or a point mutation with that. And you see there gliomelanoma, sarcoma. Those are the cell cycle regulators. So when you would get to cell cycle, these guys are supposed to be, these cell cycle regulators are supposed to catch these mutations from happening, and then these would be problems in that regulation. Next up is that it evades growth suppressor genes. You turn it on, you should have a way to turn it off. Proto-oncogenes are the way that we turn the cell on. Tumor suppressor genes, if the cell does get this tumor growth, we have two basic suppressor genes that are really high yield when we're talking about tumor suppressor genes, and those are RB and P53. They will regulate cell growth and hence suppress the risk of tumor growth. So if it gets turned on, this is going to try and turn it off. They are inactivated and they allow for uncontrolled growth. So you lose the stop mechanism. In response to the DNA damage, P53, which is called the guardian of the genome, slows the cell cycle and upregulates DNA repair enzymes. If not possible, then apoptosis is started. What's interesting is it's a two-hit hypothesis that both copies of P53 must be blocked to allow for tumor formation. So you got two of them. It is seen in over 50% of all cancers, this two-hit phenomena, that we lose P53. So let's take a look at P53. It monitors intracellular signals related to stress and activates caretaker genes. They are responsible for the maintenance of genomic integrity. Many types of cellular stress, okay, so this is what we talked about back in cellular injury. Any types of those cellular stress, anoxia, oncogene expression, nuclear damage, produce intracellular signals, and then we will get other indicators of cell abnormalities, and that's detectable by the P53. Here we have a normal cell. P53 is normal. We get that DNA damage. It then P53 accumulates and binds to DNA. Transcription dependent and independent effects on targets. So depending what's going on, it will put the cell in senescence, basically saying it's retired. We may have a successful repair, and you can see a couple different pathways here, the GAD45 or the P21. We get successful repair, we go back to a normal cell. We do not have successful repair, then we go to apoptosis. So over here, there are a cell with mutations or loss of P53. So we have the same ionizing radiation, carcinogen, or mutagens. We get DNA damage. We do not get P53 genes not activated. So we get no cell cycle arrest. We get no DNA repair and no senescence. We get mutant cells. We get expansion and additional mutations, and we end up with a malignant tumor. Now, if we look at the RB, which is the retinoblastoma gene, normal cells receive diverse anti-growth signals from their normal environment, then contact with other cells with basement membranes factors normally signal the cells to stop proliferating. The RB monitor that anti-growth cellular signals and block activation of growth and division in cell cycle phase. If there's mutations in the RB, so here we have hypophosphorylated, we will end up getting a transcriptional block. This will then factor into regulating the gene controlling passage through the cell cycle. Growth factor regulated kinases increasing phosphorylation, so that would be the hyperphosphorylated RB. What this allows for then is unregulated and continual cell growth. This gene is mutated in childhood retinoblastoma and then many lung, breast, and bone cancers as well for the RB. Usually with the RB, it's a point mutation on one allele that allows for that, and it ultimately will lead to the retinoblastoma. One of the effects that happens with the cancer cells is this growth promoting metabolic alteration. So this is called the Warburg effect. Cancer cells demonstrate this really distinct form of cellular metabolism, which is high yield because they basically use aerobic glycolysis and not oxidative phosphorylation. So the Warburg effect is known as aerobic glycolysis, recognized by Otto Warburg back in 1931. It is this glucose hunger, and that's actually what we look at for when we're using PET scans. And we use F-fluorodeoxyglucose, which is a derivative of glucose, and it basically is preferentially taken up by the tumor cells or cells that are high turnover, and that's how we can use it to detect cancer with the PET. It's an increased conversion of glucose to lactose via the fermentation via the glycolytic pathway. So these quiescent cells rely mainly on the Krebs cycle for adenosine triphosphate production. If starved, autophagy, self-eating, is induced to provide the source of fuel. When stimulated by the growth factors, normal cells markedly upregulate glucose and glutamine uptake, yielding glycolytic and Krebs cycle metabolic intermediates. Those provide carbon sources for synthesis of nucleotides, proteins, and lipids. In cancer, these oncogenic mutations involving growth factor signaling pathways and other key factors actually deregulate these pathways. So just like we talked about deregulation back here with the growth factor, it's still on that same line, because remember that we're getting glycolysis in the cytoplasm, and then in the mitochondria is where we get the oxidative phosphorylation. So here is, glucose is taken in, we get those mediaries, which go for protein synthesis, also amino acids, lipogenesis. We get that in that process, but what happens here is this pathway is altered because we have tyrosine kinase receptor issues, so all of it ends up being downstream of the signaling of the pathway. Reprogram the metabolism because they need to have increased cellular demand and they need more protein synthesis amino acids, lipogenesis. Tumor cells often seem to be able to grow under marginal environments, meaning that we lose that autophagy, we lose that turnoff, we lose the ability to get rid of the bad cell. Another way that we have changes related to neoplastic process is evasion of cell death. So remember that we have that individual programmed death called apoptosis, where under certain circumstances, cell senescence, basically the cell will dismantle its components and then consumed by the macrophages. That autophagy does not have inflammation that follows it. Remember that we have those two pathways, intrinsic and extrinsic. So the intrinsic pathway is when we have that mitochondrial pathway, and that is initiated by various stressors, such as the absence of growth factors, DNA damage. So that's what the intrinsic is. So we can have DNA damage. The extrinsic pathway is the death receptor pathway, and this is triggered by tumor necrosis factor receptor families such as Fas ligand. What happens are these pathways, whether it's the intrinsic or extrinsic, are dysregulated in the cancerous process, and it basically allows for the cancerous cell to evade and then suppress those apoptotic pathway, which means that the cell does not die. We have this limitless cell life. Another way is that it's going to evade senescence. So remember we said that those old cells basically will be taken away by autophagy. The cell takes care of itself, doesn't divide again. It leaves cell cycle permanently. That is what cell senescence is. With cancer cells, they lose those cell cycle checkpoints and are virtually allows the cancer cell to bypass cell senescence so that it will keep turning over. It basically does not get turned off. Another thing it does is they evade mitotic crisis. And what this is that cells that are resistant to senescence have increased replicative properties. They are not immortal, but instead they eventually enter a phase referred to as mitotic crisis and die. Mitotic crisis has been ascribed to progressive shortening of the telomeres. Those telomeres are at the end of the chromosomes, remember? As the cell senescence happens, these telomeres basically shorten. So what's happening here is this progressive shortening of the telomeres. That process eventually leads to cell death. What happens for the cancer cells is that they never hit the mitotic crisis. There's also self-renewal. So cancer cells are basically immortal and limitless proliferation. An example of the regulator of apoptosis is the BCL2. This is involved in normally blocking cytochrome C, and that stops the release from the mitochondria. And remember, if cytochrome C is activated, it activates apoptosis, which is lost and therefore allowing for no apoptosis. So BCL2 is overexpressed in follicular lymphoma because we don't have any cell death. Other things that we need to talk about with the cancer metabolism and the environment, they love it hypoxic and acidic. They basically are parasites and use whatever they need from nearby cells. They use the glycolysis instead of oxidative phosphorylation, which again allows for their more efficient and rapid growth. Telomerase is necessary for cell immortality, and that's what we were talking about. Normally they shorten with serial cell division, resulting in cellular senescence. In cancer cells, these are upregulated, which preserves them. Also, which is high yield, is angiogenesis. Cancer cells actually produce new blood vessels so that they get extra nutrients and they can grow and survive and live a long life and try and kill you. Another key thing is that they avoid immune surveillance. So we talked about the CD4 and CD8 and major histocompatibility complexes, and we basically present antigen. We also talked about if there's cancer in that cell, it would be an MHC class 1. If it's internal, MHC class 1 is expressed on all cells except for red blood cells. And basically, if something's going on within the cell, it will present whatever is going on. So what happens with this, there are downregulation of MHC class 1, meaning the cells do not express it, and that then will allow for the immune system not to surveil that cell and allows for the cancer to proliferate. They are basically under surveilled. that autocrine stimulation, which is where they secrete their own growth factor so that they can upregulate the growth factor receptors and also get that cellular proliferation going on. This is a high yield slide. So when we take a look at everything that we talked about, there's basically 8 fundamental changes that come with cancer. And I have the picture which is in your book. This is also a very common picture that you will see. And these are the ways that cancer proliferates. Moving on to tumor progression, invasion, and spread. So this is a nice little picture of what it's going to look like. So we have cell with genetic mutation. We get that hyperplasia, dysplasia. We get that in situ. Remember that it doesn't cross basement membrane yet. But it is proliferating and it is growing. Then we get invasion and spread. And that is the accumulation of mutations eventually spread into the basement membrane and ability to spread and metastasize. Other things that happen with invasion and spread is the epithelial tumor cells are attached to one another by cellular adhesions. This is downregulated, leads to dissociation of the cells, and basically allows for the tumor to come in. So here where the cells are tightly together because of the cell-to-cell adhesion molecules, what happens is they become downregulated, so it allows for these to pull apart and easier spread. It also allows the cells to attach to the laminin and destroy that basement membrane. Also will attach to the fibronectin in that extracellular matrix and then spread locally. Then we get entrance into the lymphatic system and vascular spaces, and then we get metastasis. So you can have local spread, and then, once we have that local spread, did it enter into lymphatic systems? So this is where we get lymph node involvement. What we mean by metastasis is the spreading, travel by invasion into the blood and lymph system, and then it is able to attach to a new environment. This is the significant cause of pain and suffering with cancer, and this is the major cause of mortality. We have a couple different types of spread, and we have a couple different features that go along with it. When we're talking about lymphatic spread, those are common with carcinomas, so it's going to spread through the lymphatic system. Sarcomas like to spread through the hematogenesis, which is your blood system. Seeding occurs with certain cancers, such as ovarian, and that's why certain cancers we do not biopsy, because we're concerned about seeding. All right, so let's take a look at clinical aspects of neoplasia. So this would be your manifestations of the cancer. We have cachexia, which is a multi-organ syndrome that is an energy balance disorder. It is a mismatch between the energy intake and the expenditure, depends on the tumor type and its growth phase. Basically, cancer patients are hypermetabolic. There are issues with muscle wasting in addition to the loss of subcutaneous fat, especially the white adipose tissue. Then we have these paraneoplastic syndromes. So these are complexes that are triggered by the cancer but are not caused by the direct local effects of the tumor mass. They are commonly caused by biologic substances released from the tumor, such as hormones, or by immune response triggered by the tumor. An example would be carcinoid tumors release hormones such as serotonin. You get some flushing, rapid heartbeat. We can get some skin disorders such as acanthus nigricans or dermatomyositis, some skeletal and joint abnormalities, hypercoagulability. So these are all related to having cancer, but not the actual tumor itself. After all of this, now we're going to grade and stage the cancer. So grading is determined by biopsy, so that we can take a look at the cytologic appearance. Behavior and differentiation are related. Poorly differentiated tumors have more aggressive behavior. Well differentiated, we consider them low-grade tumors, resembles the parent tissue, good stuff. Poorly differentiated, high-grade, aggressive, not resembles the parent tissue, and that's usually a bad sign. It's very important in determining prognosis. We also then have staging of cancer, and this is determined by surgical exploration or imaging. It is going to be the assessment, size, and spread. Key prognostic factor. It's actually more important than grade, and it is determined after the final surgical resection of the tumor. Tumor size and depth of invasion, spread to regional lymph nodes. Metastasis is the most important prognostic factor. So have we spread? Other things that they'll look like when they're doing cystology and cancer surgery, they're going to be looking for receptors, tumor expressing genes such as BRCA, epithelial growth factor, HER2. It further subdivides the cancer, and then it also drives that prognostic treatment. So we really can hone in on how to treat the cancer. What are the important ways that we diagnose cancer? So the laboratory diagnosis of cancer and core, we have to have morphological methods. We have to be able to take a look at the cancer cells. So that is either going to be biopsy, excision, fine needle aspiration. However we need to get the tissue, we have to be able to look at it under a microscope and take the cytology. Then we also take a look at tumor markers. These are certain substances that are put off by the tumor cells, and we usually take a look at those for treatment purposes. New things, molecular diagnosis is polymerase chain reaction, so PCR, and germline detection. So here we take a look at a Circos plot, which shows the genetic alterations in a lung cancer patient. So here, each of the chromosomes in the cancer is displayed in a circle format. The positions of various tumor-specific aberrations are mapped basically on the chromosomes. You can see here we have A, B, C, and D. A is going to be structural rearrangements in the chromosomes. B is going to represent where there is a loss of heterozygosity and allelic imbalance, and that's going to basically mean one allele is overrepresented versus the second. C is going to represent the copy number profiles. So if there is a number loss, it's going to be in red, and if it's a gain, it's going to be in blue. And then D are the point mutations. They are represented as red dots. So a few tumor markers. So these are substances that are produced by cancer and other cells of the body in response to cancer being there. These tumor markers are proteins, but could also be a hormone, enzyme, antigen, or antibody. So it really could be any type of process. They are patterns of gene expression and changes of DNA that have also begun to be used as tumor markers. And then there is a couple tumor markers. Cancer in children and adolescents is actually rare, but it is still a leading cause of death. Remember, accidents was number 1, cancer number 2. Cancer in children and adolescents is rare, but it is still a leading cause of death. Remember, accidents was number 1, cancer was number 2. The 5-year survival rate of children and adolescents with cancer has improved from 59% up to 85% today. So we've gotten a lot better about treating and curing and doing well with this. They believe that factors that are leading to those improved cure rates are that we have chemotherapy, the development of those targeted therapies, including immunotherapy, and then also the fact that we are getting children into clinical trials. For these cancers, most of them originate in the mesodermal germ layer, which is responsible for your connective tissue, blood vessels, kidney, lymphatic system. And those most common cancers are leukemias, sarcomas. Then we have those embryonal tumors, which are derived intrauterine, and they believe it is related to the fact that the embryonal cells do not mature and differentiate, and they get this blast formation. Leukemia is the most common malignancy in children, and it usually occurs between 2 and 5 years. And if it presents, it's usually acute lymphoblastic leukemia. The solid cancers will end up being your brain CNS tumors. When we're talking about the adolescents, we get more into the lymphomas, leukemias, adult-like cancers with that. Interesting enough, with epidemiology, boys are going to be more than females. Caucasian, white are going to be more than African American, black. When we look at etiology of cancer for children, it's really it's very different than what we look at with environmental factors for adults. In fact, they really don't know why these cancers develop. There are tumor suppressor genes and oncogenes associated with childhood cancers. You can see here the rearrangements, whether it's a deletion, a translocation, all depends what's going on. But really, the evidence is quite lacking to tell us why childhood cancers arrive. And that's why I have the question marks behind all of them, because there's really not much data on the etiology of cancer. The high yield meds are DES, which was diethylstilbezitrol, which was prescribed by physicians to prevent spontaneous miscarriage, but then it was identified to be a chemical carcinogen. Anabolic steroids, chemotherapy if they had one cancer. Childhood exposure to ionizing radiation, drugs, viruses has been associated with some cancers. The high doses of ionizing radiation is an established risk factor. Epstein-Barr virus has been the only one with a relationship to cancer in children, and that is that Burkitt lymphoma. The good news is a child develops, it's more than 85% are cured. Those are pretty good odds. The problem is that young children are particularly susceptible to long-term sequelae from treatment. So they get treated so young, depending on what type of chemotherapy. If it's an alkylating agent, we talked about certain issues with alkylating agents and then later leukemias. So it does put you at risk if you do have to treat early. All right, let's look at some selected neoplastic disorders. Here is a wonderful pathophysiology flow chart for the leukemia. So I just thought this was really nice. I really love this website. Check out thecalgaryguide.com. So you can see there point mutation or chromosomal abnormality, combinations. We get issues with white blood cells and their precursors, neoplastic blood cell. Then we have the monoclonal mother cell, and we have that one cell originates all successive cells. Here you can see that initiating mutational event related to CML is the Philadelphia chromosome, high yield, and that is the BCR and the ABL gene translocate on the chromosome 9 and 22. The other ones are related to point mutations, chromosomal alterations, and other abnormal genetic, creating that neoplastic cell. So acute versus chronic leukemias. It's characterized and classified as acute because it is the undifferentiated and very immature cells. So it's higher up on that hierarchy. Usually the acutes have a quick and rapid onset and they have a short survival time. Chronic, they are more differentiated leukocytes. It is not 100% normal, but it is much closer to being able to function than an acute situation. So these guys clearly do not function. They are immature, undifferentiated, and blast cells. Let's take a look now at acute leukemias. So this is going to be acute myelogenous or acute lymphoblastic. They are a neoplastic proliferation of non-functioning blast. Diagnosis, we have to have greater than 20% in the bone marrow. So how are we doing this? You would have to have a bone biopsy to be able to diagnose this. What happens with the blast cells is they crowd out normal hematopoiesis, resulting in acute phase. We get a lack of pretty much all of our blood cells. We will have anemia, thrombocytopenia, and neutropenia. Acute lymphoblastic leukemia, so those are a neoplastic accumulation of lymphoblasts. Again, acute blasts greater than 20% in the bone marrow. These guys, so what happens here is TDT is absent in myeloid blasts and mature lymphocytes. If there are blasts present, we stain for this TDT, and if it's present, then we know that we have blasts. Okay, so that's one of the ways that we take a look for the leukemia, lymphoblastic leukemia. There are also B or T based surface markers on them. This one is the one that occurs most commonly in children. Also, there's a risk with Down syndrome after the 5-year mark. Clinical presentation, some of them do have unique features. So this would be palpable lymphadenopathy, bone pain, left upper quadrant fullness, and that is related to splenomegaly. And then you may have a mediastinal mass related to the T cells, right? Where is the thymus? Remember, you can have B cell or T cell because you have lymphocytes. Acute myeloid leukemia. So now we're in that other line, and then it is acute. So it's going to be very immature myeloid cells. This is commonly seen in older population, 50 to 60. We have a couple different cytogenic abnormality and subclasses, 20% in the bone marrow. And then we are going to be cytoplasmic staining for this myeloperoxidase. Moving on to chronic leukemia. So this is a neoplastic proliferation of mature circulating lymphocytes. This is characterized by a high WBC count. We have two main types, chronic lymphocytic leukemia and chronic myelogenous leukemia. It's very slow onset, seen in older adults. They are mature, but remember, they are not 100% functioning. So we have this progressive accumulation of functionally incompetent lymphocytes. They are monoclonal. Remember, all cancer is monoclonal. There is this thing called active disease, and this is where therapy is initiated. These B-related symptoms are fevers, weight loss, cachexia, night sweats, fatigue, and weight loss. Chronic lymphocytic leukemia, proliferation of naive B cells. Remember, when they have not been presented, they are naive. Most common leukemia, involvement of the lymph nodes leads to generalized lymphadenopathy. We have increased lymphocytes, and if we do a smear, there are going to be smudge cells. Related to naive B cells, we will end up having problems for infection, right? So if we have naive B cells, we have half of our adaptive immune system gone. Hypogammaglobulinemia. Infection is the most common cause because we don't have adaptive immunity. You can get autoimmune hemolytic anemia and thrombocytopenia. You can transform into diffuse large B cell lymphoma, which is not a good situation. That is called Richter transformation or Richter syndrome. And what happens is you would get diagnosed with CLL. You kind of are running baseline, and then you would get enlarged lymph node presentation or spleen enlargement. Chronic myeloid leukemia, we're looking at the myeloid line, and that is any of the mature myeloid cells. This would be that Philadelphia chromosome, so translocation 922 chromosome, BRIC and ABL fusion protein, which is going to increase kinase receptors. It is pathonomic. If you see Philadelphia chromosome, you better know that it's CML. It has massive myeloid hyperplasia of the bone marrow, causes abnormal expansion. Splenomegaly is common. You can have a chronic myeloid leukemia versus a leukemoid reaction. You would have to differentiate. With chronic myeloid, there's a slight male preponderance. Median age is 65. Lymphoma. So now we're getting a neoplastic proliferation of lymphoid cells that form a mass. So this is not a circulating cancer. This now forms a mass. We have two types, non-Hodgkin and Hodgkin's. Some are indolent, waxing and waning over years. Others are highly aggressive, resulting in death pretty quickly. So there's a wide range of presentations with lymphoma. We then will further classify as B or T cell, what cell sizes, what's the pattern of growth, surface markers, cytogenic translocation. So there are a whole bunch of lymphomas. Hodgkin's lymphoma, so this arises from the germinal or the post-germinal center of the B cells of the lymph gland. And it's a neoplastic proliferation. This is pathonomic Reed-Sternbein cells. You will have B cells with multi-lobed nuclei and a prominent nucleoli. The Reed-Sternbein cells secrete cytokines, and then we get this reactive inflammatory cells that make up the bulk of the tumor. You have classic Hodgkin's, and then you have a nodular lymphocytic predominant Hodgkin's, the two main types, and that's based on the appearance and immunophenotype. You're not going to know this until we take a look at the cells. There's an increased risk of Hodgkin's lymphomas with patients that have had mono. So Epstein-Barr, remember, oncogenic. All right, next up we're going to talk about MGUS, which is myoclonal gammopathy of undetermined significance. That is what MGUS stands for. This is kind of a pre-cancerous situation. This clinically asymptomatic pre-malignant clonal plasma cell situation. So we're getting these monoclonal gammopathies. Don't know exactly what's going on yet, but it's asymptomatic. Usually patients, it is found incidentally on blood work. So what happens when they look at the serum electrophoresis is there's an M spike, and that is usually an incidental finding when we get a serum electrophoresis for another cause, such as acute kidney issues. But we won't have any clinical features of multiple myeloma, and I'm going to talk about that in a minute, what those clinical features are. Common in the elderly, and it can progress to MM. Other things that MGUS can progress to, Wallstrom macroglobulinemia, chronic lymphocytic leukemia, and other types of non-Hodgkin lymphomas, light chain amyloidosis, plasma cell proliferative disorders, and B and IgG or IgA gammopathy. So it would affect those two. So they do question a familiar component because there's a 2 to 3 fold increased risk in the first degree relative. There is potential link between autoimmune diseases or an infection precluding the diagnosis. Prevalence increases with age. It actually presents 2 to 3 times more in the African American community than the Caucasian as they're younger. Once we're age 50 and older, then it increases in the white population. More common in men than women. So what is multiple myeloma? So that is that malignant proliferation, most common primary malignancy of the bone. We can have bone mets, that's a secondary malignancy. This is the most common primary malignancy. Where is it happening? In the bone marrow. There may be high serum interleukin 6, stimulates the plasma cell growth and immunoglobulin production. 7 per 100,000, 65 to 75. Only 10% less than 50, only 2% less than 40. And we see male again, African American, then Caucasian, then Asian, over Mexican. And there's that possible inheritance pattern, and then ionizing radiation and petroleum products. The clinical features. So if we have MGUS, we will not have any of the clinical features of multiple myeloma. We will just have that isolated M spike on the serum electrophoresis. Bone pain with hypercalcemia. Usually, this is one of the reasons that we will start testing. If I have hypercalcemia with no known etiology, I actually will be looking for multiple myeloma. So here is the pathology, the pathogenesis behind why these present. Take a look at it. Lytic or punched out lesions are seen on x-ray. That would be high yield as well, because that means that we are having this rank receptor leading to bone destruction, and we get these punched out lesions. We will have elevated serum protein. That is that M spike on the electrophoresis. It's IgG or IgA. We will be increased risk of infections because we do not have that antigenic diversity because they're immature, naive B cells. We have a relay formation of RBCs on the blood smear. You could have amyloidosis, and that is these free light chains circulating and depositing in tissues. Proteinuria, another big thing. Free light chains will be in the urine as Bence-Jones protein, deposit in the kidney tubules, risk for kidney failure. That is one of the things that we also look for. So if there's any kidney issues, we usually pull a serum and a urine electrophoresis because we're looking for these indications of multiple myeloma. Serum and a urine electrophoresis. This is basically looking at your gamma globulins and seeing if there's that M spike. We will also look at serum free light chain assays, CBC. You're going to see if there's anemia, thrombocytopenia, and also what are the white blood cell counts. Ultimately, you're going to end up with a bone marrow aspirate, biopsy, PET scan, skeletal survey once we know what's going on with these things. So this would be initial, and this would be second. And your differential is the MGUS, Waldstrom macroglobulinemia, amyloidosis, and then heavy chain disease or light chain disease. Quickly, just look over the treatments. We all know there's basically 3 types. You're going to get chemotherapy or immunotherapy, which basically takes advantage of certain vulnerabilities of the cancer cell. Looking at antimetabolites, DNA damaging agents. Some of them are hardcore and kill everything. Some of them are very targeted. It all depends. So newer agents are using that molecular analysis to really pinpoint what's going on. Radiation, depending on what type of cancer it is, basically the radiation will kill the lethal cell. Potentially lethal will be wounded, eventually die. Sublethal will repair itself. Most rapidly renewing cells are sensitive to radiation, very well suited for brain, prostate, breast. Surgery, definitive treatment if the cancer has not spread. Select high-risk diseases. Surgery can be preventative. If there is the APC germline mutation, which is 100% risk of cancer, so they may perform a prophylactic colectomy. I remember that APC stands for Odenomys polyposis coli gene. BRCA1 and 2 have markedly increased risk of breast and ovarian cancer, so some women will have a prophylactic double mastectomy to take away the breast tissue that will then not be stimulated. That is it for neoplasia.